here today with PSI and Internews, partnering here at Women Deliver. We are joined today by young leaders here at the conference, youth activists and advocates in their respective communities. So can you tell me what are some of the challenges and barriers that you face?
Kenya, the biggest challenge that we face is that policies. You find that there are no direct policies that state that adolescent girls and young women can get these services, especially contraceptive services. There's policies restricting these services to being given to adolescents. So we find that service providers and other community other health community leaders that we engage, sometimes they are hesitant at giving these services because they feel like there's no that policy that protects them. They're like, if we give these adolescents contraceptive services, I'll talk about contraceptive mostly because that is the area that we are implementing in. Find that at some point the service providers will be like, no, the government may take action on us, and there is not that direct policy that is preventing them or protecting them from, if they give these services to adolescents, maybe they won't be taken to court. Another barrier that I can talk about is consent. You find that dealing with adolescent girls and young women, it's really hard because everything they have to ask consent. They have to seek consent from their parents, from their spouse, from anyone that is leading them. So as much as we are trying to create urgency for this girl, as much as we are trying to make this girl be able to make their own decision in life, but there's still that aspect of still going back to the community and asking for permission for this girl. This is her right. She should seek services from the facility, but we as a program or as an entity, we should just go back to the community and ask for consent. So that's something that is also a challenge.
In the context of Ethiopia, we also have similar challenges. When it comes to the RISE program, so it deals with married adolescent girls 15 to 19 in the rural communities. So Ethiopia is very large landmass, and there are many topographies, highlands, lowlands, and we are dealing with communities at the low level. So where the girl lives in the rural areas, usually the culture goes, the girl gets married and she moves from her own town to another community, another village. And in that village, she doesn't have social network connections with other people. She gets neglected, and she doesn't know about the services that are available to her. And sometimes there is also challenge from the service providers because, as Alice was also mentioning, these girls are not 18, so there is a legal restriction. Why are they married? If they go to the health center, they are scared that they might be accused of getting married. And there is attitude from the service providers as well. We have seen similar challenges. And commodities, facilities at the low level, they're not being fulfilled. The health extension workers, they have to cover very large areas, and the facilities they serve in are in a very low condition. And there is also lack of commodities at those facilities. So addressing the needs of those girls will become even more challenging. These girls they're being left in the middle because from their family side, their husband's mother-in-laws, they're forcing them to have a baby. Maybe they didn't get into marriage even it might have been an arranged marriage. So from the social side as well as from the institutional side, they are not being served and left in the middle. So while we are trying to address the challenges using the RISE project, which focuses on meeting the needs of those girls, we have seen many challenges.
The 360 project is in two different regions in Nigeria. It's in the northern region and the southern region, and they are very contextualized. In the northern region, we program for married adolescent girls, and in the south, we program for unmarried adolescent girls. And one of the major challenges of the 360 programming are the deep-rooted, social cultural norms that we have, which actually informed our programming, and we see it cut across the different areas of ASRH intervention, which affects girls between the ages of 15 to 19. So for the unmarried adolescent girls, we have to go through their key influencers and ensure that we create that enabling environment for ASRH to thrive and for the girls to have easy access to contraceptive uptake or SRH services in general. So for the northern aspect, the challenges are quite a lot, but we find that the MMA program is finding ways to accept the contextualized challenges and program for girls in that direction. As a youth advocate, one of the major challenges that we face is meaningful adolescent and youth engagement. How does the country engage engage youth and adolescents meaningfully in the aspect of sexual and reproductive health intervention. Because at that decision making level, we just see policies rolling
Yeah.
out. Youth are not at the center of these policies. How do we ensure that youth are sitting at that table, ensuring that whatever program is coming out for sexual and reproductive health, youth has a voice in it?
What I can say is that there's parallels in each country in Africa. Kenya, Ethiopia, Nigeria, there's parallels of the challenges that we face. When funders hear this conversation, they're like, oh, they're all facing the same problem. That means that when we run programs, we give them a program and it's all the same program. And that's not going to work. Hopefully, from this conversation, which leads me into my next question, what is your call to action to change makers, policy makers, funders, government leaders, presidents, people who are here at this conference, who are speaking and saying that they're representing?
Meaningful adolescent and youth engagement is very important, and we need to incorporate that from the grassroots levels. We have so many potentials, so many skills untapped, at the grassroots level, starting from the community to the health facility to the LGA level for Nigeria, to the state level, to the national level. We should have youth representative at various grassroots, and they should be prioritized. Not only prioritized, there should be funding attached to it, because majority of what we hear is, we have meaningful adolescent and youth engagement. We are just there. We are just tokenized. We are just there to say, oh, youth are there. Youth are part of the programming. But in the reality of it, we are tokenized. So it's not just putting youth at the community level. No, we are doing that and we are not seeing any changes. There should be funding. We should prioritize youth-led organization, because we are closer to the grassroots. We know what the youth want. We know how to, intersect and, collaborate with our youth within the communities and ensure that, their voices are included. They should prioritize governance structure and ensure that policies favors youth. Policies favors meaningful adolescent and youth engagement across, the various stratas within the economy, within the system, not only health.
Semi has said almost everything. She has said everything. Meaningful adolescent youth engagement is what brought us here. Meaningful adolescent engagement is the reason for Smart Start, Binti Shupavu, and all the other programs. We have seen the results of the engagement. What are we waiting for? It's a really question. And even if we consider the population, for example, in my country,